and thanks for studying with me today. My name's Dr. Meredith Watkins, and this is 360RN. Today's lecture is on osteoporosis. This is a musculoskeletal disorder, and it's part of our Med-Surg nursing series. Now, this series is best supported by getting the study buddy system that goes along with this, so that you can follow along with active note-taking, do practice questions, case studies, reflections, and so on. So make sure you grab the study buddy that goes with this. It's in the description box below. And without further ado, let's get started. These are all the topics we're going to cover about osteoporosis: pathophysiology, risk factors, signs and symptoms, diagnostics and labs, what treatments are available, and then some nursing considerations like assessments, interventions, what complications to predict, teaching points to give to the patient, and our nursing evaluation. Now, if you're familiar with nursing concepts, osteoporosis is most closely related to mobility and safety. So pull in all of that information you know about mobility and safety and let that influence what you understand about osteoporosis. And in terms of body systems, osteoporosis is most closely related to the musculoskeletal system. So everything you remember from your pathophysiology class on musculoskeletal system will help influence your understanding of this topic. So what is osteoporosis? Well, osteoporosis is also known as brittle bone disease. It causes weak or brittle bones over time. And this happens as calcium leaches out of the bones. Why does calcium leach out of the bones? Well, our body needs calcium for a lot of really important functions. Remember from your fluid and electrolytes lecture, calcium is needed for the heart, for muscle function, and for nerve function. So when the body doesn't have enough calcium, the body will steal that calcium from the bones and suck it into the bloodstream to be used for more important functions at that time, like our heart rhythms and muscle and nerve function. And so the parathyroid hormone is really responsible for overseeing this process and deciding when it needs to borrow calcium from the bones. Now, if the body doesn't have enough calcium for regular everyday functions, the parathyroid hormone will tell the bones to release calcium into the bloodstream. And over time, if this happens a lot, it causes a lack of bone density, which puts the patients at risk for fractures. Now, I want you to think about the bone matrix inside a bone as kind of like a Swiss cheese look. So our normal bone has some spaces inside the bone, and then as we move into osteoporosis, we see that there is less and less bone density because calcium is being pulled out. Now, the first stage of osteoporosis is called osteopenia. It just means low bone density, but not full osteoporosis. And then as it gets worse, the patients develop osteoporosis or even severe osteoporosis. Now, obviously, we need strong, healthy bones to support our bodies and to protect us if we do fall. And so patients who have really brittle bones can get fractures from just really simple falls that if they had healthy, strong bones with good bone density, they wouldn't have fractured from. Now, the name of the game here is to find out who's at risk for osteoporosis and intervene early. And we can break risk factors for osteoporosis into 4 areas: non-modifiable, modifiable, different conditions and diseases, and finally medications. So let's break down each of these separately. Non-modifiable risk factors are things you don't have control over. So the non-modifiable risk factors for osteoporosis include advanced age, over 50, postmenopausal, female, and patients with a family history. So the most common people that we're going to see with osteoporosis is postmenopausal females. Now, you can't change your age, you can't change your sex, you can't change your family history, but there are some modifiable risk factors that you could change and have an impact on. Modifiable risk factors for osteoporosis include low calcium intake, low vitamin D intake, I just lost my light in my room, there we go, high phosphorus intake, because remember from fluid and electrolyte class, overall calorie intake. Additionally, patients who do not exercise, who smoke cigarettes, or have an excessive amount of alcohol, we're talking more than 3 drinks a day, are at higher risk for osteoporosis. Additionally, there are some conditions and diseases that can cause osteoporosis or put someone at higher risk. So anyone who has early menopause, any GI disorders, especially ones that relate to absorption of nutrients in the intestines, liver diseases, or other mobility issues that could cause their bones to have leached out calcium in the past, things like previous hip fractures, prolonged immobilization in hospital, or history of frequent falls. All of these things are going to be additional risk factors. And finally, medications. Now, there are a variety of medications that could put patients at higher risk for osteoporosis, but the most common and the one you should know is steroids. Corticosteroids decrease bone density over time, so patients who are on chronic steroid use, think people who have autoimmune disorders, for example, are going to be at higher risk for having osteoporosis. Now that we've talked about risk factors, let's talk about what you would notice if a patient had osteoporosis. And here's the bad news, guys. The bad news is that a fracture is usually the first sign of osteoporosis. So we really, as nurses, have to pay attention to those risk factors to hopefully avoid them from having this happen in the first place. Now, if a patient does present for a fracture, oftentimes it's a fracture and their fall wasn't even that bad. You know what I'm saying? Like, they wouldn't necessarily have had a fracture given the circumstances if they had healthy bones. Now, fractures that are caused by an underlying disease are called pathologic fractures. And so pathologic fractures are often the first sign or symptom someone has related to osteoporosis. And of course, we'd like people to be able to avoid having the fracture in the first place. So we want to screen patients for increased risk. And the gold standard for diagnosing osteoporosis is called a DEXA scan. DEXA scan stands for dual energy X-ray absorptiometry, something like that, or just a DEXA scan. It's a bone density scan, and it's able to look at the density of the bone matrix itself. Now, when patients go for these procedures, you can see it on the screen here. It's an open X-ray with a piece of the equipment that goes on top of them. The patients lay down for this. It takes about 10 minutes. It's non-invasive. There's no pain. There's no injection. It's kind of like an X-ray. It's just a special X-ray machine. There are some things you should know. Patients should not have any calcium supplements 24 hours before this test, as it can influence the test results. Now, most patients who are getting osteoporosis screenings are probably on calcium supplements, so we want to make sure we tell them that. Additionally, we want to avoid any metal zippers or buttons that could interfere with the study that would show up on the images. Of course, we want to assess pregnancy status because we're doing things with X-ray. And the patient should not have any barium enemas or CT contrast dye procedures within the last 2 weeks. Other than a DEXA scan, calcium and vitamin D levels will often be drawn, as those nutritional deficits can cause osteoporosis. I know I'm sounding like a broken record, but prevention is key. Identifying risk factors and working to reduce modifiable risk factors. So consider the risk factors for your patients that you're working with. We're going to screen patients who are greater than 65 with a DEXA scan, or females between 50 and 64 who are considered higher risk. We want to encourage patients to have lifestyle changes like weight loss, encourage strength training exercises, exercise in general, to avoid smoking, and to avoid excessive alcohol intake. Additionally, we can consider nutrition as an important aspect of preventing osteoporosis. If you remember from the 80s and 90s and you've seen the Got Milk commercials, the government really got involved in making sure kids had enough milk in school programs to hopefully reduce brittle bone disease later on in life. But calcium doesn't just come from milk. And you can see here in this example that you can get calcium from sardines, from cheeses, from fruit, from leafy greens like broccoli and spinach, nuts. There's a lot of different sources that patients can get calcium. And then patients also need good vitamin D, which of course we can get from sunlight. But in the northern hemisphere, we often don't have enough sunlight to be able to get the vitamin D we need. And if we're using sunscreen, which we should, the vitamin D is not able to convert in our skin. So supplementing with calcium and vitamin D is very common in addition to getting sunshine and eating things with calcium. Now let's talk about the pharmacologic treatments that are offered to patients with osteoporosis. Supplements, like we said, vitamin D and calcium. Remember, vitamin D helps calcium be absorbed better, so we always have those taken together. There are some hormonal benefits like estrogen, calcitonin, or parathyroid hormone that providers may prescribe. But the one that I really want you to know the most about today is the biphosphonates. This is the most common drug class given to patients with osteoporosis, and it helps to inhibit bone reabsorption. It blocks calcium from leaking out of the bones and into the bloodstream. Examples of this are Fosamax and Boniva. The most common side effects are heartburn and stomach upset. And so we want to teach patients to avoid lying down for an hour to avoid that heartburn. Take it with a full glass of water and take it on an empty stomach. Now, if you are assessing a patient with osteoporosis, you want to assess their fall risk because you know if a patient who falls who has osteoporosis is more likely to sustain a really severe injury from that fall. So check them for fall risks, check their mobility status, do an environmental safety screen of their area so they're not going to trip and fall over things, do an assessment of their nutritional status, if they're getting enough calories and enough calcium and vitamin D, and then also assess their activity level. Remember that strength training exercises can help with increasing bone density. Nursing interventions are going to include administering medicines as prescribed, encouraging exercise, and possibly considering a home health referral who can do an environmental safety check of the home to make sure there are no loose area rugs, or if there are stairs that need a handrail, any safety issues in the house, because again, we don't want patients with osteoporosis to fall. They're really likely to break a bone. Complications of osteoporosis include falls with bad consequences. They break bones easily. Immobility related to fractures, hospitalization related to broken hips and broken bones, and all of these things can lead to death. And so while we don't think about osteoporosis as being a maybe emergent issue like a heart attack or a stroke, the consequences of a fracture in an elderly client can be life-threatening in elderly patients. So we really do want to make sure that we are helping build strong bones in our patients earlier on in life, screening for patients with osteoporosis, and preventing falls. Teaching for patients with osteoporosis is pretty straightforward. You're going to tell them to take their medications and supplements as prescribed and to modify their lifestyle. No excessive alcohol, avoid smoking, do some strength training exercise, maintain your healthy weight. Now, when we evaluate care, we're looking, did our implementation and interventions work, or did they not work? Is the patient getting better? Is the patient getting worse? And in your study buddy, you'll see a section that has a plus section and a minus section under evaluating care. So what we're looking for are those positives. How do we know that our implementation worked? Well, we're going to see the patient have good medication compliance. They're going to have those lifestyle improvements, like they might decrease their alcohol, they might stop smoking, start an exercise routine, start working out with weights. We would notice on their DEXA scans that they have improved or at least maintained bone density. And if they do have a fall, we would see that they would be fracture-free. So those are the positives we're looking at. Now, if we're looking about a negative, meaning a patient whose treatment plan is not working very well, we would notice a patient who is not compliant with their medication. They're not improving their lifestyle They're having worsening bone density on their DEXA scans, and they're having fractures through when they fall. So those are the negatives that we're going to look for. But again, we're evaluating our care to make sure that the implementation and interventions we did are working for the patient. That's all for this video lecture. Make sure you finish up your study cycle in your Study Buddy workbook. That includes the practice questions and the case study, the reflection. I'll see you next time. Thanks again for studying with me today.